All right, so fluid overload is a significant side effect or consequence or complication of a patient with CKD, right, with chronic kidney disease. All right, so what causes fluid to be overloaded? So sodium, where sodium goes, water goes, right? So if your sodium's high, that's going to cause the water to be high too. So we got to do what? We have to restrict the sodium, right? And then also might as well restrict the water too while we're at it. All right, so sodium and water restrictions. So it's about 2, right? So 2 of sodium per day and 2 of liters per day, right? So make sure we are reducing their fluid intake and reducing their sodium intake. And then it's like, cool boss, got it. And they go out into the wild. Do you think they know what to do? No. So you have to know what to teach, right? So how to teach a low sodium diet, right? Aim for about 2 grams per day. Avoid high sodium foods. That means something that's processed. So what's processed? That's anything that you get from fast food, basically, right? So, or processed meats, processed items that have more than like 5 ingredients are probably going to have a lot of sodium in it. Okay, canned foods have preservatives. Preservatives are known for having sodium too. Monosodium glutamate from from Chinese restaurants and such. All right, things that say instant are not great. Things that say cheeses and meats, spreads, frozen meals, they have a lot of processed things in it. And those are going to have a lot of sodium in it, right? If you look at the sodium on it, it's going to say, whoa, 800 milligrams. I guess that's okay, right? But how many more of those can you eat? 1.5, right? So you can eat, because another 800 is 1,600, and what's our limit? 1.5 to 2 grams, right? So we could squeeze another, oh, that was a really good lean cuisine. I got to get another one, right? Another half one. That could, those are your 3 meals for the day. But either way, cured smoked meats and salt such as MSG, something that says pickled or brined, right? So what's something that's pickled or brined? Pickles. And what else? What else is pickled or brined? Sauerkraut, right? You got a sauerkraut fan in the back. There's no kimchi fans, right? You got kimchi, you got olives. These things are brined, right? A brine is a salt and vinegar solution that you put things in, right? So you can't be doing any kind of 3-month journeys across the Atlantic Ocean. Everything's gonna be brined, right? You can't have like beef jerky that's brined, it's salt, right? Baking soda or baking powder, the ingredient is sodium bicarb, right? Which is sodium. So you gotta be careful of that. So breads and such, and things that just say sodium in it, right? It says sodium on the label. Right? That's probably not great. Oh, no one said sardines. Why nobody's a fan of sardines? Anyways, all right, you got one. All right, there's always one. All right, so anyways, these are going to be high in sodium, and we have to limit these things. So that means on the test, you got to be able to recognize, oh, that's a high salt diet. I should not recommend that diet, right? So some tips are to prepare your own food. Do not add salt. Don't have soy sauce at the table. Don't have salt packets at the table. What kind of packets can you have at the table? Spice, right? So you have spices that don't have salt and spices that don't have what? MSG and potassium in it. For our hypertensive patients, we say, hey, don't do the salt, right? Low sodium diet. Why don't you use these salt substitutes, the little packets of salt substitutes. And the salt substitutes, if you look at it, is full of potassium. So that's great for someone who's hypertensive, not great for someone who's what? Hyperkalemic or with chronic kidney disease, right? And oftentimes, a little tip is to titrate. So it means that start at what you're doing right now. Every day, take away some salt, and after 10 to 14 days, it'll kind of reset your taste buds. That's the life cycle of a taste bud, right? So you'll get more used to having low salt in your diet. So when you then try some chip, everybody had cut out salt for a second, right? And you come back to eating regular because you couldn't do it or you couldn't afford it, and it was you eat like regular salt potato chips. It's like, it's really, really salty. So that's because your taste buds are not used to it, or really, really oily or greasy when you come back to it. And then you get used to it after a while. To keep how do you know those Oreos? I can do this. And then after a while, the Oreos don't taste that sweet anymore, right? But if you cut them out for like 2 weeks and you eat Oreos, well, that's super sweet. Okay. And then choose fresh things, right? And then you can do low sodium items, things that say no salt foods, things that have less than 4 to 5 ingredients. Using lemon juice is recommended, garlic, vinegar. Well, I thought vinegar was in brine. Well, brine is vinegar and salt. All right, so vinegar things. There's all kinds of fancy vinegars and balsamic vinegars out there. There's like a flavor for each each one. There's just straight balsamic vinegar, and there's like balsamic vinegar that has spice, and one that has that sweetness, and there's all kinds of different options out there nowadays. Okay, using herbs and spices, seasoning blends, but not ones that say salt substitutes, because you have to look at the back. It probably has really high potassium in it. All right, so breads and rolls, not recommended. Cold cuts and meats, not recommended. Sandwiches, not recommended. The bread has sodium. What makes bread rise? Yeast and bicarb, right? The baking powder or baking soda, right? Those two things make it rise. Okay, so that's probably not recommended. Pizza is just bread, right? It's just a sandwich and that's open, right? So then we got sliced meats on it as well. We got cheeses. Cheeses usually are really high in sodium as well. All right, got soups. Why are soups bad? But it says low sodium, but it has like 25 preservatives. So that's not going to be recommended. All right, and then we'll have fluids. So fluids need to be about 2 liters or less, 1.5 to 2 liters or less. So how do you get by with that? Because someone's like, I have to drink. I just bought this bottle off Amazon, and it says, drink now, drink more, drink more, drink more, right? So that's you're not going to recommend that. You're going to give them small cups to drink out of. So you got to serve yourself a little small cup of water. So here is a little small cup of water. It's actually a regular sized cup with shack, but that's a little small cup right there. So, that's what you should be drinking, right? How much does the cup have in it as far as cc's or mLs? 200, right? So 200 cc's is, that you can only drink so many cups, right, before you get, and that's just drinking, right? We have meals, and meals have fluid in it too. So like, I'm not sure who has a meal of Jell-O or ice cream, but Jell-O and ice cream counts as well. Like, no, that's separate. No, it is the same. That is also considered a fluid. Okay, fruits and soups have fluids in it that we have to make sure we're keeping track of, right? And then we should be able to give fluids throughout the day. So we're not doing all the fluids in the morning. Now they have 16 hours to deal with, 2 cups of water. We should probably stretch it out as much as possible. There's this recommendation of using a 2-liter bottle. This is before the invention of the smartphone, when you have apps now that can actually tell you how much fluid you intook throughout the day, right? You can say, I drank a cup of water. I can look at my watch, I took a cup of water, and it adds it for you. So that's much more updated 2024 reason, but not everybody's in 2024. We have some people that are elderly, they don't use smartphones, they just pull out their razor, right? And they pull out their BlackBerry with the wheel. So there's some people that are still living back in the past, and we have to be able to, say, hey, you got a 2-liter bottle at home. So whenever you drink 240 cc's or 200 cc's of water, you also pour it into the 2-liter bottle. That's a recommendation. Use small cups like we mentioned, just sip, don't like, right? And we're done, right? We want to make sure that we are going to be sipping slowly. Okay, measure the fluid consumed throughout the day, and the 2-liter bottle we mentioned. Take pills instead of water. All right, so that's nice water. That's more nice water. That's excellent water, and they already finished a cup of water. So take it with applesauce or yogurt is a recommendation. If they're thirsty, we got hard candies, sour candies, lemon slices that it will trick yourself. It'll pull the water out of your body into your mouth, and you'll drink that. It's like drink your own water. So that's one tip and trick is use sour candies, sour grapes, even frozen ones. That way they have to work on it for a while. So it's like you're going to work and produce water for more period of time, right? So you're like 50% water, 50% of what you actually intook, all right? Using alcohol-free mouthwash, because what does alcohol do to your mouth? It dries it up, right? If you use alcohol all day or the hand sanitizers, and we use hand sanitizers in the hospital setting, yeah. So anyways, that's going to dry out your hands, right? So we can use alcohol-free mouthwash, keep their mouth feeling fresh. They can brush their teeth frequently. All right, they should be monitoring their weight as well, doing daily weights. It's for us in the hospital, daily weights, but for them, they should monitor their weights to see if they are gaining extra weight. One of the reasons when we call 911 for these guys, or when we teach them, is if they gain a CHF patient, if you're gaining extra weight, that means your kidney disease might not be being controlled, or might be getting worse. Something might be going on. All right. So too much fluid is if you're getting more than 1 kilo per day. That's definitely a problem. Okay, so non-dialysis patients, usually you can total how much they took in the previous day, all right, or how much output in the previous day, and that's how much they can take today, right? Plus insensible losses. What's an insensible loss? So it's something you can't measure. What can't you measure? Sweat, right? You can't measure how much someone is sweating, right? You can't. I guess you could weigh the bed and subtract it, but that's too fancy. But what else can't you measure? Tears, all right? So that's a high capacity in this program. But what else can't you measure? Breathing, right? You can't measure how much someone is exhaling, right? When you exhale CO2 and you exhale water, right? If you have glasses or you have a desk in front of you, you can blow onto the desk, not blow, but onto the desk, not hawk a loogie on a desk, but on a desk, and you'll see water vapor show up, right? So that's my water vapor, you're gonna take it back, right? If you have a CKD. So dialysis patients, they don't pee, so we really have to pay attention to their weight, okay? So they're gonna have all this extra fluid, and it's like, oh, so what? They got extra fluid. Well, that's going to start causing more problems. All that fluid is going to put extra stress on the kidneys. It's going to put stress on the other organs or abdominal organs. All that extra fluid can leak into the brain, causing a little confusion as well. All right. It can put extra stress on what other organ that we talked about? On the heart, right? Like put a lot of extra stress that is undue. So we want to recommend a sodium restriction and a fluid restriction. Okay. All right, so our patients that have fluid restriction, we got to make sure we teach them appropriately. All right, so make sure you are restricting fluids. You wouldn't give them that huge bottle. You'd be giving them little cups. All right, so potassium and acidosis. So hyperkalemia and acidosis are a big consequence, and they can be a lethal consequence. And why is it lethal? Why is it lethal to be hyperkalemic? Because your EKG is going to start failing, right? So your EKGs, everything's going to start getting prolonged. And before it gets prolonged, it's actually going to get a little peak T wave, right? A little peak T wave, and then every single interval gets prolonged. QT, PR, QRS, everything gets longed. Imagine if you have a little string right here, and you just pull it this way. That's what happens. It just pulls all the way out to a sine wave to asystole, right? So that is a bad consequence of just hyperkalemia. But it's complicated by acidosis, because acidosis also causes hyperkalemia. So you have both of these to deal with. Okay, so metabolic acidosis is you're not getting rid of acids, right? Acids that you are producing and acids that might kill you, right? So these acids could be building up also. Besides us not getting rid of acids, and we are already a little bit acidotic, now we introduce someone that has an infection, or we introduce ketones if they have diabetes. And what complication has ketones in diabetes? Diabetic ketoacidosis, right? So that's going to cause a rise in our acid levels, and that's going to cause a what in our pH? It's going to cause a lowering of our pH. What's that going to do to our bicarb on our ABG? And bicompensate, which means what?
No, oh, but that's wrong. Sorry, that's wrong.
It will compensate, and not compensate, but it will. Your kidneys will try to compensate, but your kidneys are dead. So what's going to happen to your bicarb? Which one? Low. It's going. Why? Why is it going to be low? Because acids and bicarb neutralize each other, right? And now you have less bicarb around because they're neutralized, right? So your bicarb level starts falling, your pH starts falling or rising. Which one was it? pH falls as well. And your CO2 will try to compensate, right? When you have metabolic acidosis, your respiratory system starts to kick in. And what's your respiratory system going to do? Breathe faster or slower? It's going to breathe faster. And when you breathe faster, what happens to your CO2 level? It goes down, right? So ABGs make an ugly return. So you have to make sure you know your ABGs, because that's going to be here as well. Someone with CKD has what ABG? Someone with DKA has what ABG, right? So that's going to be something to look at. Okay, so when you have all this acidosis, that's a trigger for the what? For the SNS to fire off. The respirator is going to fire up. They're going to breathe in super fast until the acidosis hits the medulla, right? And the medulla is like going to be chugging away until it gets so acidotic the medulla can't keep up, right? And then you're going to start breathing slow, because your medulla is what raises your heart rate and resting rate to begin with, right? And then your whole brain is going to start shutting down. Everything's starting to be denatured and not working good. And you're going to start getting comatose. And then, of course, your heart can't work. And one of the H's and T's are what? Related to metabolic acidosis? Hydrogen ion excess, right? So that's where hydrogen ions are in excess because we can't get rid of them in CKD. Okay. And also, when you have hydrogen ion excess, the hydrogen ions are like, oh, it's too acidotic out here. Let's put those in the cell in exchange for what? potassium. And then the potassium comes out, it's like, it's too high out here. I'm going to go back inside, right? And then that's going to be, and then it's like, they're going to, no, you go back outside. So they're going to be acidotic and hyperkalemic, and that's not good, okay? So how can we fix it? Well, we fix the underlying problem. That's always the right answer. I'm going to fix the underlying problem, right? I'm going to fix the diabetes or hypertension. But like right now, what can I do? What they can usually going to be on like a sodium bicarb, like a PO form. They can be on that at home or in the hospital setting if they're pretty stable. Otherwise, I might be on an infusion of bicarb, right? That infusion of bicarb will, they build up all these acids. Like here, let me help you out, right? Help another out. You just hook up an IV, hook up a bicarb infusion. Bicarb pushes don't really work, but bicarb infusions and PO bicarb can work, okay? And then we talked about hyperkalemia will develop. Your potassium, you can't get rid of the potassium because the way you get rid of potassium is either peeing or pooping it out. And once it's made its way from the GI tract to the bloodstream, you can't put it back. You can't put and then the potassium goes from your bloodstream into your gut. That's not a thing, right? So you have to stop it in the gut. And how do we stop it in the gut? We can bind it, right? How do you bind it? I heard piss, but no, it's not piss. You're going to give medications to poo it out. You're going to bind it. Caxylate, patiramir, or sodium zirconium. These guys are to poop it out. Sodium zirconium, the brand name is Lokelma, which is a nice name. It lowers my K, right? And they usually give that to kidney disease patients because we want to make sure that we avoid the hyperkalemia. But what if the hyperkalemia is leading to the worst case scenario, which is what? Acidosis, and then acidosis causes this too, which is what? Is EKG changes. What medication can we give to control the EKG changes? Nope. Calcium. So calcium is going to be the agent we give to stabilize someone's heart if they have hyperkalemia, right? So calcium is always our go-to. That's the most emergent agent we would give, right? So if someone has hyperkalemia and the doctors say, oh, let's give this, and then you look at the monitor, well, they got a prolonged QT, prolonged PR, and they got this really bradycardia. It's like, well, shoot, you need to give calcium. Calcium will stabilize that while the other ones work. Calcium is like a movie science where you give it, ooh, look, it just changed. It gets narrow right away. And then when it wears off, it spreads right back out, right? So the other ones, though, work in about 2 to 4 hours. So the calcium works right now. All right, so we can push it into the cells as well, push that potassium into the cells, right, to hide it for later, right? So you can pee it out later, but what if they don't pee? Well, we have another option, which is what if they can't pee? How do we take it out of the bloodstream? We can't poop it out. We talked about that. That's not a process. We can do dialysis. You can take it out. You can take the potassium out of the bloodstream with dialysis. And before you can do dialysis, you need to have a access for it, right? So we talked about in central lines, you have 2 accesses you can use to get dialysis, to perform dialysis, which are what? A vas cath or a permacath, right? A tunneled catheter or a non-tunneled catheter. Which one's tunneled? Permacath is a tunneled catheter, okay? So we can push the potassium into the cells. How do we do that? With insulin and dextrose, because if you give insulin to someone and you say, okay, I'll check on you in an hour. It's like, what if their sugar was 70? Right? And you just gave a push of IV insulin, not a sub-Q, but an IV push of insulin. It's going to work really, really fast. So you should probably get some dextrose with that. Right? So dextrose is also going to stimulate your body's own insulin, and that's now you guys like a 2-for-1, right? We're all about recycling today. So you're going to use your own insulin, and when you get someone's dextrose. Bicarb drip is preferred over IV push. Right? So IV push is actually going to pull potassium out of the cells because it's so strong at pulling things. But so you have potassium in the cell, it'll pull everything out when you give that bicarb. It's so osmotically active. But a drip, like an infusion, like at a 75 an hour, 100 mLs an hour of bicarb infusion, bicarb in a 1 liter bag, that's going to neutralize the potassium and acidosis over time. And then we got albuterol, not what's the other A beta blocker? Atenolol. So not atenolol, but albuterol, right? So LOL versus OL, which one's the beta agonist? OL is a beta agonist. Where else do we use albuterol? In asthma, as a SABA or SAMA or as LABA or LAMA? As a SABA, right? As a short-acting beta agonist, right? And then we can pee it out. If the kidneys still work, because there's 5 stages of kidney disease. There's stage 1, 2, 3, 4, or 5. If they're stage 5 and giving a diuretic is just, that's like peeing in the ocean. It's not going to do anything, right? It's going to, you're not going to say, oh, that's not, it's not, the furosemide is not going to work, right? So you have to be able to give furosemide to working kidneys. Sometimes we'll just try it out, see if it works. Oh, it worked. Look at that, you peed, right? Otherwise, it's not good. It's, you know, to get this potassium down, furosemide can be used. A diuretic can be used, right? So that's part of the potassium cocktail with a K, right? So potassium cocktail. The mnemonic is a big dick, as in like a big detective, right? So big detective, you know, detectives are called dicks. So he's going to go in there, he's going to eliminate the potassium, okay? So A for albuterol, B for bicarb, I for insulin. We got, what else? G for glucose, like D50, right, is our usual ones. We got D for diuretics, H/I for hemodialysis, right? And we got C for calcium and K for crapping it out. It used to be for Kexlate, but we don't do Kexlate as much anymore. But we got 3 things, including Kexlate, that we can use to get rid of potassium, right? And that is a patiromer, sodium zirconium, or Kexlate. You'll still see Kexlate around, unfortunately. All right. So otherwise, this is like an emergent situation. Someone's potassium is high. What is a high potassium level? Greater than, usually greater than 5, greater than 5.5. That's really where you're going to start being worried about getting some intervention, such as medications. But otherwise, once they leave the hospital or as an outpatient or the recommendation or grandma calls you, I just got diagnosed with CKD, what should I do? Because you're going to use a low potassium diet, right? You should recommend a low potassium intake, so 2 grams per day, approximately. Avoid high potassium foods, and it's really like potassium is in everything. Potassium is in every living cell, so it's kind of hard to say, oh yeah, don't eat cells, but everything's made of cells, so what do I do? All right, so certain fruits are really high potassium, so you really want to kind of focus on like the top 10 at least. That's going to be telling you, oh, it's definitely avoid beet greens. Like, oh shoot, I love beet greens, all right? And then salmon is really high in potassium. White beans, but not the gray beans or the black beans. I don't know, it's just the white beans are highest in potassium. Avocados, oh no, my avocate. All right, so that's going to be high in potassium, unfortunately. Potatoes are high in potassium. Eggs, squashes, dairy products. All right, so bananas they make number 9. Everyone's like, oh, bananas, avoid bananas. It's actually number 9 on the list. On top of my watch mojo right there. And then tomatoes are also on the list. So someone eating spaghetti sauce, not great, right? Someone eating meats. Do meats have cells in it? They have once living cells, unless you order it rare, right? So they probably want to avoid meat intake as well. So leafy greens means more living cells, right? That means that's why it's dark green. It has a lot of extra living cells in it, so we avoid leafy greens. Foods that have been lysed, what does lysed mean? Dead or destroyed. So how do we destroy a grape? You put in a dehydrator for 3 days at 100 degrees. It's like, yeah, I showed you, right? So that's going to be, so you eat prunes, which is a dried what? Plum, right? So prunes are probably not recommended. A dried raisin or dried grape? A raisin. You would avoid raisins, prunes, things that are in the ground usually have time to produce potassium. Nuts and seeds are probably not recommended. So it's like, what the heck can I eat? It's like, well, that's why you would then use a smartphone app or something that's going to be, you know, that you could give them a little tip sheet like this. It's like, here, don't eat this if they don't have a smartphone. Otherwise, we have watches and such. They say, oh, you're at 2 grams already. It's like, well, shoot, I guess I'm done for the day, right? That's the most recommended. And then what about salt substitutes? So salt substitutes are, for the previous slide, oh, that's great. It doesn't have sodium in it. But it has what in it? It has dead things, right? Things have been dead, and then we slice them up and blend them up, and we put in a little package. And that is dead things that you're adding to your food, right? So salt substitutes have dead things in it, and thus it has potassium in it. So we would not recommend salt substitutes. Does salt substitute have salt in it? A lot of people get that question wrong. So salt substitutes do not have salt in it, please. All right. So what can I eat? So these are some recommendations here. But use rice versus bread. But bread's there, but bread has salt in it. So that's why using apps nowadays has been like a game changer. So you can easily see what you're eating and what your salt intake is, what your fluid intake is, and such. Right? You need to develop a hospital app for your patient. That'd be swell. That way you can then track it right there in the bedside. Okay, so potassium is in every living cell, so we got to avoid things that have high potassium in it. All right, so azotemia. So azo means what? nitrogen, but it's excess nitrogen products. And what's the nitrogen product that we build up? BUN. So the BUN is going up. So elevated BUN is going to cause problems, a lot of problems. BUN is a waste product. It's not. It should be peed out. But we have chronic kidney disease. We cannot pee it out. So it builds up. And because of it building up, and we said because it has like a little multipass and it can go everywhere, that means it's going to cross into the brain. It's going to cross into the pericardium. It's going to cross into the skin. It's going to cross into the bone marrow. It's going to cross into the coag cascade and stop all these things. It's also going to cross into the endothelium line of the vascular space, and it's going to damage it as well. So we got all this body-wide dysfunction. So platelets don't work good. So if your platelets don't work, what are you going to get? Bleeding. So there could be a high bleeding risk. And we can be like a little cheerleader for platelets if we give them what's called DAVP. And you can go ahead and give them this. That's also the witness protection name for what? For ADH or vasopressin. So its other feature is that it can be given for someone that is at risk for bleeding. So prior to procedure, someone's BUN is super, super high. We can say, well, let's give them DDAVP to prevent a bleeding event, right? Endothelial damage will damage the lining of the blood vessels. That's the endothelium, and that will cause a damage and let atheromas develop. Yes?
What is DDAVP?
D-arginine vasopressin. All right, so DDAVP is just vasopressin or antidiuretic hormone, right? It's in witness protection. Remember we mentioned it has different names, right? So it's another function besides vasopressing and retaining fluid. It's also going to be used to be a cheerleader for platelets, right? It actually provides a little bit of clotting boost. Okay, so endothelial damage can occur, right? And we have endothelial damage. That's perfect groundwork for ASCVD to take work, right? Atheromas can develop, fatty streaks can develop, and then we now have ASCVD or hypertension, right? Now that's going to damage our kidneys even more. And then if we don't damage our kidneys, we could get CAD. If you have CAD, you get an MI. If you have an MI, you can get CHF. You get CHF, you have no flow to your kidneys. No flow to your kidneys, you get the SNS RAS fired off, and you get hypertension. And now we're back, and then that damages your kidneys more. And so it's a whole downward spiral that we have to stop somehow. Okay? So SNS tone is actually also increased when you have BUN around. It just makes the SNS fire off more, which is not going to help someone with CHF or someone with kidney disease. And then we got the parathyroid hormone, which we'll talk about calcium and phosphorus coming up. But it's going to disrupt that cycle as well. It's going to make the more parathyroid hormone around. And parathyroid hormone is going to take calcium and phosphorus from your bone, and you got bone problems. So we'll talk about that. And then it's like a perfect recipe of calcium being elevated, phosphorus being elevated, and this urea being elevated. It causes your vessels to literally become calcified. So it calcifies your vessels just like diabetes did. So that's going to also do what to your blood pressure? That's going to raise it. So that's going to also cause more damage to our kidneys. All right, so bone marrow suppression, so that's not good. It's going to suppress your bone marrow. What does your bone marrow do? It's going to make RBCs, it's going to make white blood cells, and it's going to make what else? Platelets, right? So platelets don't get made, so we get a bleeding risk again. But white blood cells don't get made, so what do you get as a side effect of that? You're at risk for infection. So infection risk is a significant risk factor when you have elevated BUN. Bleeding is a risk factor, and the RBCs are going to be low or high with bone marrow suppression. Be low, so you get what? Anemia. What are anemia symptoms? You get DOE. What does DOE mean? Dead on arrival. Dyspnea on exertion. So they walk, and they get short of breath, right? And then you say, oh, let me listen to your lungs. I got my stethoscope right here. And you listen to their lungs, and what do they sound like? Are there crackles? Are they clear? Are they absent? They are clear. You've got clear lungs, but dyspnea on exertion. If you have cloudy lungs or you have crackle lungs and dyspnea on exertion, what's that? That's called CHF, right? If you got wheezes and dyspnea on exertion, what is that? That's asthma or COPD, right? What if you have absent lung sounds and probably with dyspneic right now? So what is that called? Or sudden dyspnea? That's called pneumothorax. And pneumothorax is a side effect or a consequence of what disease process? Of not CHF, but another C, COPD. They get spontaneous pneumothorax. They're just resting there, pop, and their lung just pops. Okay. So signs and symptoms of uremia, of elevated BUN. Obviously, if you do the labs, your BUN is going to be high. What's a normal BUN? It's just your respiratory rate, 12 to 20. All right, so 12 to 20 is a normal respiratory rate and normal BUN. So if it's going higher, 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 it's like, what'd you eat? All right, or they just have kidney disease. All right, so that's going to be high. And then we mentioned that BUN can go anywhere at once. It can go to the skin and start accumulating. It develops what's called a uremic frost, not like a salt and pepper, but uremic frost. Right? It's not gonna look great. Right? So you're gonna have all this development of this, and it's really itchy also. This itchiness, this itchy skin, and we can't just say itchy skin, we have to say what? Pruritus. They have pruritus, and they have this uremic frost, and it can then cross into the pericardium and cause their pericardium to get inflamed, and what's that called? Pericarditis. I thought I had it here, pericarditis. Anyways, am I just missed it? Okay, I can't see it because I'm hyper-focused. Anyways, pericarditis will happen as well. Pericarditis will develop, and then what's that have symptoms of? If you have pericarditis, what are you going to auscultate? A friction rub, right? It's going to sound like what? Like, okay, like leather. I can't do a leather sound. I can't do that one. All right, so it's going to have that leather rub. Yes?
Is the uremic frost just like skin flakes or something?
Yeah, it's like skin flakes.
Okay.
All right. All right, so then you have this pericarditis has what other symptoms besides a friction rub? They could get tamponade after a while, but before that, they would have what symptoms would they complain of? They complain of chest pain, right? And what kind of chest pain? Chest pain that's positional? Yes, so they have positional chest pain. So chest pain that gets better or worse when leaning forward? It gets better leaning forward, it gets worse leaning back, right? So that's the pericarditis that can develop from uremia. So what if the BUN keeps rising and rising and rising, and it gets into the brain and crosses the blood-brain barrier? At first, it can make you altered, right? It can make you a little altered, somnolent, sleepy, and such. But it eventually is going to start interrupting many, many processes because it's like a hoarder. They're going to hoard all this BUN. Or throw this away. No, that's my BUN, right? I need that. That's mine. So what about this? That's also my BUN, right? That's my BUN I had broken down from my protein that I ate in 1975. It's like, okay, because protein, that protein you ate in 1975 is going to be made into eventually urea, right? Urea is just two amines, right? What makes up a protein are amino acids. So you break down two amines in a CO2 molecule, and now you have BUN, right? And that BUN is now perfectly non-polar, so it can perfectly go wherever it wants. And it goes into the skin, like we said, and now into the brain. And if it goes to the brain, we can get encephalopathic, which means a pathy of our encephalum. Our encephalum is our brain, right? So we get disease of our brain. And it's due to the BUN getting higher and higher and higher. Usually the BUN is greater than 100. That's where they're starting to get these symptoms. Okay? And there's no fix for this. There's no medical treatment you could give to bind to someone's BUN because you're like, you can't catch me, right? It's just going to leave, right? So how do you get rid of BUN? The only way you can do it is through dialysis. You can only take it out through dialysis. All right, so besides getting comatose and somnolent and sleepy, they can also get seizure activity, and they get what's called asterixis, or asterisks if you're American. All right, so you got this little asterixis here where you hold their hand back and they move like that, right? It kind of looks like a tremor, but usually you can produce it by just pushing their hands back, and you let go, and it will beat for you. Okay, so that's asterixis. And we got pruritus, and we got uremic frost on there. Why do they get hypertensive? Because it directly stimulates the SNS, so that's a problem. Okay, and we got that calcification of the arteries. We got the uremic pericarditis there. And then treatment-wise, we said dialysis, but in the meantime, we can recommend a low-protein diet because that protein that we ate is going to get made, the excess protein is going to get broken down, right? It's like, oh, you didn't go to the gym today. Shame on you, all right? It's like, oh, you had to, I already had to live with this shame. But then otherwise, all that extra BUN is going to be made because of excess protein breakdown. Excess protein is broken down into BUN, and hopefully it gets excreted by the kidneys. But if you don't have a kidney, it has to be taken out by what? By dialysis. Okay, so low protein, about 0.8 per kilo per day. All right. If someone's on dialysis, you actually recommend a high protein diet because dialysis actually takes out proteins too. So it's this is like pre-dialysis is low protein. Okay, so that's the idea behind uremia and azotemia, right? It's causing a increased sympathetic tone. It's causing endothelial damage. It's damaging the RBC, preventing the RBCs from producing, and it's also disrupting calcium and phosphorus. Okay, so here's the calcium phosphorus story. Okay, so calcium phosphorus, I think would be orangey again. All right, so why is our calcium phosphorus messed up? Because our kidneys can't get rid of it. All right, they can't get rid of calcium, they can't get rid of phosphorus. So why isn't my calcium high also? Because again, we've got a Romeo and Juliet situation here, right? So we have phosphorus, oh, look at that, it's calcium. All right, so they're gonna go ahead and bind to it, right? And they're going to then what's called precipitate, right? Where two things bind, and they come out of a solution. They're going to come out of a solution out of the blood and precipitate onto the skin. And if you think that's going to be itchy? Yes, they get pruritus because of that. All right, calcium, they get pruritus, and these little crystals that form on the skin. All right, that's on top of the uremic frost. So all the little crystals develop. They can get what else? They can have low calcium symptoms because you're using up all the calcium, and you studied low calcium last semester, right? What are symptoms of low calcium? You get Chevostek and trousseaux and torsades, right? So these are all things that will happen when you have low calcium. So what does Chevosteks look like? That's tapping of the cheek, and the cheek is very, very irritable, right? So it will contract very easily. Just like why you have low calcium, that's also a reason why you have ectopy on the heart. And that ectopy can lead to torsades, right? Not trousseaux. So what is trousseaux? Trousseaux is the blood pressure cuff. I don't know. It's the blood pressure cuff. I don't have a good mnemonic for that one. All right. So Chevostek is one, and the other one's the other one. Okay. So the calcium phosphorus is binding itself. The phosphorus is building up because you can't get rid of it, and it's binding all the calcium. So the calcium is going down. And then we have vitamin D. Vitamin D is activated in the kidneys, right? So you get the sunlight comes in, and then it goes to the kidneys for the final activation. That's its final form. That it trains at is at the kidneys. So if your kidneys are dead, the training center is closed, and you don't have activated vitamin D. And what does vitamin D do? Vitamin D do what? It absorbs calcium and phosphorus from the gut, right? So vitamin D is going to absorb calcium and phosphorus from the gut. So here's vitamin D right there. It's going to absorb the calcium and the phosphorus. Don't have vitamin D, you're not going to absorb the calcium and phosphorus, right? So you're not going to be able to replace what was lost. And then your body's like, well, shoot, I need calcium and phosphorus. So where am I getting calcium and phosphorus from? Where's calcium found 97% of the time? In your bones. So you're going to take the calcium from your bone, and you're going to put it into the bloodstream. You're going to take the phosphorus of the bone also and put it in the bloodstream, and then that's just like putting more predators out there, and it's going to cause more binding and more problems, right? And the hormone responsible for that is PTH, so parathyroid hormone, is going to go to the bones and tell the bones, break down your bones, I need the calcium and phosphorus, it's time to go, right? And it's also going to say, but it's fine, we're going to get rid of phosphorus. And the cow's like, well, why are you bringing phosphorus too? Don't you just see me? So it's going to go actually say, no, we got a plan. We're going to go to the kidneys, and we're going to tell the kidneys to just get rid of phosphorus and hold on to calcium. So they get there, the kidneys are closed. So now we have an excess problem. Okay, and because we took all the calcium and phosphorus from the bones, that's going to be it's like, what's the robbing Peter to save Paul or whatever? It's going to cause the bones to do what? Get thin, which is called penia. They get osteopenia, and then they get broken, right? So they could get fractures. They could get these guys, someone with CKDs, like why'd you break your leg? Because they had the calcium and phosphorus leached from their bones by their own body. Okay, so how do we fix that? So we got to give them vitamin D. That makes sense, right? If you can't make vitamin D, give them vitamin D. But now we're back to the square one where you got calcium and phosphorus from the bone. If I give vitamin D, I'm going to get calcium and phosphorus from the gut. Like, what kind of guarantee do I have? It's like, well, don't worry. We're going to work on the gut, and we're going to tell the gut not to. We're going to actually take the phosphorus, and we're going to, just bind it, right? So that the phosphorus stays in the gut, and only the calcium gets absorbed. So that's what's going on here. We give a phosphate binder. So someone takes the phosphate binder by mouth. It goes in there, right? So there's stool in the gut, and then there's a phosphate binder right here, and then phosphorus has to go sit down, right? To say, okay, I'm now part of the stool, right? So vitamin D is also taken, and the vitamin D is there, and it says, okay, come calcium and phosphorus, and then calcium comes, and then where's phosphorus at? It's in the stool, right? So it doesn't get absorbed. So that's the idea behind someone with calcium and phosphorus that's low. You're going to give them vitamin D, and you're going to give them a phosphate binder, right? You're also giving calcium too, just to help out. All right, so those are the kind of the agents we give for someone with CKD that has low calcium and high phosphorus. We bind the phosphorus where? In the gut, and then we give them vitamin D because they don't make vitamin D. Because you can give all the phosphate binders you want, but if you don't give vitamin D, it's not going to do what you intended, right? The other thing that I classically see in the hospital setting is, the student will come up to me, he's like, my nurse said to hold the, to go ahead and get, because NPO accept meds, I said, go ahead and give the phosphate binder. What's it going to bind? It's not if they're NPO. If they're NPO and you give a phosphate binder, what's it going to bind? It only binds to food. So should you take this with meals? Yes, you take a phosphate binder with meals. And then there's the other one that's great is the dialysis nurse says, no, don't give the phosphate binder. It's like, well, that's the most powerful dialysis machine I've ever seen. That's going to pull the phosphate from the gut into the blood, and then it's going to take it through the dialysis machine. That's not going to happen. So phosphate binders are given when? With meals, right? If they're NPO, it doesn't make any sense to give it. Okay, so we're going to give vitamin D, calcium supplements. Usually we give what are called nephro caps or multivitamins designed for Disney patients, for the kidney patients, right? So kidney patients need to get vitamin D, right? Should their multivitamin have excellent phosphorus source on the bottle? No. So we take out the phosphorus. We provide more of what they need. We provide the vitamin D. We provide some calcium there. We provide some iron and folic acid and B12 as well, right? So the next slide we have like anemia, right? So all those things are going to be provided to them. And we can lower phosphate, right? How do we lower phosphate? Well, phosphate is found in milk and dairy and yogurt. Happen to be that Greek yogurt is fine, but other yogurts are not okay. So phosphate is found in proteins. Why are they found in protein-rich things? Because those protein-rich things needed phosphorus as energy, right, at one time. And there's a lot of phosphorus in muscles and ATP in muscles, so it makes sense we should avoid eating mussels. Not like the sea thing, but like shelled mussels, but muscle meat, okay? And then phosphorus additives. There's a lot of additives out there that have phosphorus in it. So for sodium, we said avoid sodium, right? So avoid processed foods. Processed foods also have preservatives. A lot of those preservatives, these are the FDA-approved ones, a lot of these preservatives have phosphate in it, so they should be avoided as well. Okay? Chocolate, cola, soda, these things also have a lot of phosphorus, a lot of preservatives too, that we need to avoid. All right, so then phosphate binders. They should be given when? Each meal. And that's going to bind the phosphorus in their gut, in the food in their gut, and not let it get absorbed, right? It forms a little gel so that it doesn't get absorbed, okay? And that's actually how the most popular one, Renagel, is given, right? That's why it's popular because, well, that's not why it's popular, but it makes sense why it's named that. It's going to go to the gut, it's going to absorb all the phosphorus there, forms a little gel so it doesn't get absorbed. The calcium from the meal can get absorbed, and you also gave them vitamin D earlier, right? And the vitamin D is going to help absorb the calcium, okay? The other benefit of sevelamer or Renagel is that it's going to also bind the fats in the gut. Well, that's a 2-for-1. We're going to take care of ASCVD and we're going to take care of CKD. So that's a nice double effect there. Okay. So we have calcium carbonate can be given. Calcium carbonate is also going to bind the phosphorus because it's calcium, right? It's going to bind the calcium and phosphorus in the gut. We have other options as well, like aluminum salts and iron salts. The iron will bind with the phosphate. The aluminum will bind with the phosphate. It just iron is very, very constipating. Aluminum is very, very diarrhea-ing. So you got to make sure we are given the right. We assess what kind of problems they have initially, and if it's okay, and then let them know this could cause a lot of diarrhea. All right. So what should they do if it's causing a lot of diarrhea? What we recommend? Stool softeners? No. Stool hardeners, yeah. So again, stool hardeners, because some anticholinergics we could throw them their way, but we could also give them. So we can recommend high fiber, right? A high fiber diet, but not Swiss chard, right? So we got to make sure they have a high fiber diet as well. Okay. So we intake all of our stuff here, right? And we absorb calcium because the phosphorus got bound, and out comes in the stool all of our, not our pee, but our phosphorus. All right, so anemia of chronic disease, or chronic anemia because of chronic kidney disease. Why are they anemic? Because what does the kidney do? It makes erythropoietin. It doesn't make red blood cells, technically. It makes erythropoietin, which will then go to the bone marrow, and the bone marrow will make RBCs for us, right? But if we have a dead kidney, we don't make RBCs that good, okay? So you have renal failure will just make us have anemia, but also that Horder, BUN, will elevate, and it'll actually also stop RBC production. So that can do it as well. And there's something called hepcidin, which is also going to make it difficult for our RBCs to get produced. So we'll talk about that shortly. All right, so what are the symptoms we mentioned? Were short of breath, dyspnea on exertion, technically, right? I put DOE. They can be fatigued. Why are they fatigued? They're moving their muscles, right? And they're moving their muscles, and that's going to cause a use of oxygen. And now it's like, I need more oxygen. Like, all I got is all I got. That's all the oxygen I can carry right now on my RBCs. So they get fatigued, dyspnea on exertion. They get tachy. Hypoxia is one of the triggers for SNS. They get tachypnic, tachycardic. And then eventually your brain, does your brain need oxygen? Yes. So your brain uses oxygen and to a certain point, and you're jogging, and you pass out, right? Because that's called not passing out, but syncopizing, right? It's like, I got syncope, right? So they've fallen over, they've passed out, okay? That's only a problem when you injure yourself. Otherwise, anemia is pretty. It's like, oh, I can live with this. I won't walk that far anyways. But when you pass out and you hit yourself on the corner of a bathroom, that's not going to be a great turnout, right? Especially when you have uremia and your platelets don't work, right? That's going to cause a bigger bleed. And then, when is it actually deadly? That's when your hemoglobin is less than 5. Then your heart is going to have something to say about this. That's why we transfuse at 7, right? Because if we let it get down to 5, that's going to cause a heart attack to happen. So we usually fix anemia with what? Blood transfusions. Blood transfusions when it's less than 7. So PRBCs are a mainstay of anemia, and our patients with CKD, and especially dialysis patients, because they don't make any erythropoietin. Dialysis patients are what stage CKD? 5. So that being said, they could be getting a lot of RBCs. What if they get a GI bleed at the same time? They're getting more RBCs. What if they get even more RBCs? What side effect is that of blood transfusion that could happen with blood transfusions? Iron overload. And how do you fix iron overload? You de-iron it, right? You de-Fe it, right? So Fe is iron. So deferoxamine is a medication we give for too many RBC transfusions. But we have all the other RBC transfusion reactions that could occur. And what are they? They got, which one do you think is going to happen the most with a CKD patient? So an ABO incompatibility is just a clear. That's not the CKD patient's fault. Infection is rare. It could happen. What is it? TACO, right? What is TACO? Transfusion associated what? Circulatory overload. That's just fluid overload, right? So are they at risk for fluid overload? Yes, right? So the doctor orders 2 PRBCs. You say, well, wait, let's slow down, cowboy. What are we gonna do? You can give a diuretic, but what if they have dialysis? That's not gonna work. But maybe if they're stage 4, stage 3, that can work. I expect them to order diuretic, right? But what if they are a dialysis patient? So you can actually give this with HD. So you can actually give it with hemodialysis. So as you take all the blood out of their body, which we'll talk about dialysis, you can return it back with a little blood product, a little tip. All right, here you go, a little extra PRBCs, right? So that is a feature that we can do with dialysis. We can add things to the circuit, and we can add things such as PRBCs. All right, so what else? So the other thing we can do to fix someone's anemia is give them EPO. All right, if they have low EPO, let's give them EPO. And you give it sub-Q. It can be given IV, but sub-Q works better because you usually give it every week, right? Sometimes 2 times a week, depends on the flavor of EPO. They got like spicy red hot, they got cinnamon chews. No, they have different varieties of EPO that are, some can work like every month. So, but otherwise, it's gonna be a sub-Q shot you give, and that sub-Q shot is what you wanted. It has the erythropoietin in it. It's literal erythropoietin. Right? And that EPO is going to do what? PRBCs, they replaced the RBCs, whereas EPO makes you make the RBCs, right? It's providing what the bone marrow wants, okay? So we provide the EPO for them, and what if you give too much EPO? You're gonna make too much RBCs. And what happens if you make too much RBCs? It's gonna start getting what? Start getting very, very crowded, right? So that can cause, that's super crowded, too many RBCs. That's going to start clogging things, like clogging the brain and causing strokes, causing hypertension. So we have to cut it off at a certain part. So usually about 11 to 12 is too much. So our goal hemoglobin for these guys, just 10-ish, 10.5. That's perfect, right? What's a normal hemoglobin? 15-ish, right? So that's why we would say, for CKD, we're going to allow it to be about 10, right? Because if we keep giving EPO, that's going to cause a hypertension, causing clogging problems, and that's not great, right? That's one of the side effects of EPO. And what about PRBCs? When do we transfuse those again? Just less than 7, but didn't get to 10. It's like but we know that we don't want to give too much, otherwise we have complications, right? And then we give them iron and folate and other things that will make the bone marrow think, well, I should make some more RBCs. If I provide more iron here, more folate here, and more B12 here, I provide all those tools, right? It's like if if you're doing chores, right? It's like your chores to take out the garbage, and all of a sudden more garbage or more folate starts building up, and more garbage, more recycle, iron builds up, and then more, newspapers. Who uses newspapers still? And more newspapers start building up, and that B12 is like, I think I should make some RBCs, right? If you're the bone marrow, so you're gonna start making RBCs when you start providing all the building blocks there. Okay, and then we could recommend high iron diets. Well, that means more meat. But that meat has phosphorus in it, and the processed meat has sodium in it. So what do we do then? The recommendation by the Kidney Society is to boil it and then dump the water. It's like, that doesn't sound great, but boiled salami, or okay. So that is the recommendation. But again, we just recommend having as low iron as possible, as low phosphorus as possible, as low potassium as possible. We can handle all these things, but you could get lost after 3 weeks in someone's junk drawer with the rest of the newspapers, right? So that's all can get lost. So that's why using like smartphone apps would probably be better, is where we should be going with these, right? So, but what you want to know is like the top 10. What are the top 10 things that have iron? Would you recommend these things? You do recommend these things, but you have to then think about, well, beef and skirt steak. It's like, well, that's super high in phosphorus. Well, do I recommend that? I can recommend cereal, right? As long as it's not bread cereal. Or like rice cereal, that works. Like, what am I, a toddler, right? So that's going to be, that can be recommended. Leafy greens, but not too leafy, not Swiss chard leafy, right? So it's a little bit technical, okay? So that's the idea behind anemia of chronic disease.